Farhana Ahmed. May I now request Dr. Farhana Ahmed from NICBD to have her lecture on steps of nano crush.
Respected panel, faculties, moderator, very good morning and assalamu alaikum. Actually, by this time we tune our knowledge regarding different bifurcation technique. Actually, there is no perfect bifurcation technique exists. Every technique has its own shortcoming. Like classical crush, there is a more metal, difficult to recross side branch with wire and balloon. Final kissing balloon, sometimes difficult, side branch opening often not circular. In mini crush, no control on how much side branch stand enters into the main branch, and sometimes may be inadvertently converted to full crush, and sometimes the main branch stand tracking become very difficult. This is the evolution of crush technique we already seen, and the latest edition is a nano crush, and the current one is a decay nano crush. In nano crush ensures minimal protrusion of side branch stand into the main branch. In classical crush, 4 to 5 millimeter, mini crush 2 to 3, but in nano crush, we allow only 0.5 to 1 millimeter of stand strut into the main branch. Double kiss ensures perfect opening of the side branch, can be done in all angles and easy to perform. This is the nano crush older version where the side branch stand is placed into the side branch with minimal protrusion into the main branch, and a undeflated balloon is positioned into the main branch. Then when the main branch side branch stand is deployed, crush has been done with main branch balloon. Then main branch stand is deployed, and then pot, after pot there is a recrossing, then the KBI, and then the repot. But now we are practicing the decay nano crush. In this technique, we adopt the advantage of decay crush in terms of side branch ostium stanting coverage without shifting of carina. At the same time, avoidance of too much stand start into the main branch, and that facilitated the rewiring of the wire to the side branch, and great success on KBI. What we done here, stand positioning in the side branch, one size smaller NC balloon into the main branch. We keep the NC balloon semi-inflated into the main branch, and the stand of the side branch pulled back to, and this inflated balloon into the main branch give guard to prevent the over protrusion of the stand into the main branch. Then stand deployment into the side branch, stand balloon pulled, and first KBI has been done with the stand balloon and placing the main balloon into the main branch. Then crush has been done with the main branch balloon with high pressure. After crush, the side branch balloon and wire removed, and stand deployment into the main branch. After stand deployment on the main branch, proximal pot has been done, and the recrossing of the side branch with a wire and balloon, and then KBI and repot. And this is the result. Let's see some practical. Mr. R, 43 years, a gentleman, presented with chest pain for 12 hours. He was hemodynamically unstable on admission. Patient was diabetic, hypertensive, and tropi was elevated. So we are dealing with the non-STMI who are hemodynamically unstable and impending heart failure. And the angiogram showing there is a significant distal left main disease with significant LAD and LCX stenosis. So our case belongs to, if you consider Medina classification, Medina 111, and according to definition criteria, it belongs to complex 1. So in this case, ACS patient in cardiogenic shock with impending heart failure, PCI might be the only therapeutic alternative, particularly in the presence of hemodynamic instability and cardiogenic shock. And we like to go for a double stand strategy here. And of course, the decay nano crush technique. And predilatation done in both vessel after rewiring to both vessel with 2.5 into 15 millimeter balloon. Then the stand is deployed into the side branch, keeping the balloon into the main branch. After a stand deployment, pulling the side branch balloon, first KBI has been done. Then the crush has been done with a with a main branch balloon at high pressure. After pre-dilatation and this procedure, the patient chest pain subsided and BP gradually become stable. Then the main branch stenting has been done with 3.5 into 48 millimeter stent. Then port has been done, then recrossing of the wire to the side branch, then final case report, and this is the final result. And the final result is also confirmed with IVAS. You see here, there is a minimum protrusion of here is the wire, minimum protrusion of the side branch stent into the main branch. And case 2, it is a relatively stable patient, chronic stable angina patient. It's a significant left main disease and with osteal LAD and LCX disease, and we subsequently go for nanocrash technique following the all steps. And this is the final result. And similarly, we did it not on non-left main cases like LCX and this branch OM. And this is before nanocrash, and this is after. And this nanocrash techniques is first described by Shubhan and Ray and presented in EBC 16. And they shown that their initial experience is compatible with the other crash technique. And later on, the Rostelli and colleagues also described the nanocrash technique in STMI patient with cardiogenic shock. They did a follow-up of 3 years. They shown that the 3-year CV mortality as outcome is statistically significant difference. No statistical significance difference is observed in other crash, and nanocrash obtained a larger improvement of ejection fraction on serial echocardiography. An advantage of nanocrash technique, a complete coverage of side branch ostium with a tiny amount of metal, short procedural time, no procedural complication with acceptable clinical outcome, low incidence of TLF, less contrast use, less procedural and radiation exposure. But the things that we taken care during the procedure is the angle. If it is a wide angle, then the minimum protrusion is possible. But when there is a very narrow angle, we should take care so that the proximal part of the side branch should not be missed.